Good afternoon, everybody. I hope you had a nice lunch, and we will start off our session on prepare for expansion of telehealth and M-health programs in India and South Asia. So, how would you like to go? I can start off with my presentation on the importance of EHR standards. So I'll just go there, and if you can just dim the lights, then people will be able to read it. So I actually chose this particular topic as because the healthcare needs standards. Without standards, we are not going to get to the next stage, because you will not be able to exchange data. Let us just, without further ado, look at what I am talking about. So you see, the problem is this interoperability. You have to have different types of data that needs to be exchanged if an integrated healthcare enterprise needs to be set up. There is a lot of confusion between these two acronyms, HIE and IHE. So I tried to expand on this, that IHE is actually what you get if you use HIE. It's an interplay of words and nothing to do with Dan Brown over here. So the HIE is a set of standards that if you follow, you will get an IHE. And an integrated healthcare enterprise is what we are looking for, the next step. A lot of data is getting generated and a lot of systems are being used, but in isolation as silos. So without exchange of the data, we will not be able to get the real healthcare enabled. Most of the care that we do in hospitals or even in general practice clinics like mine or specialist clinics are sick care. But we are moving away from sick care to preventive care and wellness. And that is where telemedicine and M-health comes into play. Although telemedicine can actually take care of sick care also, and in fact that is what it principally does, but it is not a very good use of that particular technology. If you want to use the technology to its fullest extent, you need to go into preventive and wellness. And the scenario is that the patient doesn't have to travel and the doctors also do not have to travel. Maybe the community nurses might have to travel, but generally you still take care of the patient or the person. Not necessarily a person who is well would not be a patient in the first place. So let us look at what are the standards. So what happened in the last year, actually in September 2010 we constituted this particular EHR Standards Committee, and the final draft was submitted in June 2013, and it was open for comments, for public comments, for about 2 months. And in August 2013, the final recommendations were submitted, and these were approved and notified by the government in September 2013. How many of you are aware that we have got a set of standards for EHR? One person, 2, 3, 4. Oh, nice, 5. But still, not the majority. So the thing is this, that this has not been very well publicized, but there is a particular reason for this, is because EHR systems are still not commonplace. But we need to be aware that these things are there. At the moment it is only approved, it is not mandatory, it is just a recommendation that you use it. But what happens is that subsequently when it becomes mandatory, and if you have developed a system after 2013, it is entirely possible that the government might come back and say, you had the standards, why didn't you follow them? You chose not to follow them, so you pay a penalty. Whatever the penalty would be, I have no idea. So let us see what is actually a standard, because this is a little confusing. So I have taken it. This is from the federal records, the 45 CFR 170.102. It states the standards means a technical, functional or performance-based rule condition, requirement or specification that stipulates instructions, fields, codes, data, materials, characteristics or actions. So that is what is basically meant by a standard. And what is required for EHR standard? Electronic health records are a summary of the various electronic medical records that get generated during any clinical encounter. Even today, a lot of documents you will find where the word EHR and EMR is used as synonyms. Please understand, they are not. The two very different beasts, if you were to call it. So every time you see a patient or a patient sees a doctor or any clinical care provider, it is a clinical encounter, and a record of that encounter is an electronic medical record, if you happen to capture it in an electronic format. Otherwise, it's just a medical record. However, if you were to sequentially place them in ascending order from the very first record till today, I'm deliberately not using the word womb to tomb because somehow it means that the patient is already dead. So I would rather say that from the very first, whatever, and most of us, we still do not have an electronic health record or a medical record. So an EHR of ours would be probably starting at whatever time it was captured for the first time. But once you have that placed, it is an electronic health record, because a health record will also have information of things that happened to you when you were healthy. Supposing you were fit and fine and you went and got yourself checked for whatever you wanted to, like an executive health checkup. All your reports are normal. You are fit as a fiddle, but it is actually a part of your health record, because on that particular day or date or dates, you were fine and these were your reports. Now if I were to subsequently see you and I find there are changes, I would know when you were absolutely fine, and then I can try and figure out what happened to you in the interim. So without standards, as you can imagine, a lifelong summary is not possible, as different records from different sources spread across around 80 plus years will potentially need to be brought into one summary. So if you, any one of you, or maybe a lot of you are from the IT field or IT background, you will understand that trying to get them all consolidated in one place and sort of do some processing, if they are not the same, it will not happen. To achieve this, a set of predefined standards for information exchange that includes images, clinical codes and a minimum data set is imperative. And this is what precisely the EHR standards gives you. I'll just briefly touch upon them. So what are we have as general requirements? RBAC, role-based access control. So if your role permits you to view certain aspects of a particular record, you will be able to do that. The rest of it will all be hidden from you. So let's say there is somebody who is registering a patient. He or she need not know what is wrong with you. Your name, your date of birth, your contact details, etc., the demographic parts is all that that person should be allowed to see, review, edit, etc. A patient, and this is very important, please understand that in this entire thing, patient is the central figure. Without the patient, nothing will happen. So the patient also will have access. And actually the EHR standards does specify that the patient is the owner of the record. The hospital or any other entity which is actually generating the record is merely the custodian of that record. So it is his responsibility or that entity's responsibility to have the records made available on demand. Yes, they can house it, no problem. But if they want to do anything with it, they need to take prior permission of the patient. So, role-based access control, digital signature. So without a signature, you cannot authenticate any prescription or any report. So a digital signature is required. An audit trail. What has been done, when, where, including whether somebody saw something, some record, somebody made some changes to the record. Please understand, you can make some changes because many times people make mistakes, but you must keep the previous record intact as it was entered at that time. And you make that as inactive, and the new one with the changed record as active. And then somebody should be able to go back and look at what was changed and why. This would be extremely useful for medical legal purposes. There are other advantages also, but that's another discussion. So accurate transcription, you need to be able to faithfully repeat the record of the data. You cannot have it lost somewhere, including error-free transmission. And you have to have the ability to display data in an informative manner, both textual and graphical. So what are the standards? So we will first talk about the codes that have been specified. The first one is IHT-SDO SNOMED CT. This is for clinical terminology for clinical observations. I'm happy to inform you all that India is now a member of IHT-SDO since first April of this year, 2014. And anybody in India is entitled to have access to SNOMED CT, the entire codes, for free, provided you use it, everything inside India. You use it for research, you use it in your commercial solution, you use it in your daily practice or whatever. It is available to you for free. There's a little challenging as to where you can get it, but soon enough the CDAC Pune has been designated as the interim national release center, and they will be handling all your requests for downloads, access to the codes. Then for laboratory observations, we have got Legenstries Institute, LOINC. For diseases and diagnosis, it is still, there was a lot of requests and demands from various stakeholders that we need to have WHO ICD-10. So it is still there. Procedures, ICD-10 PCS, and disability ICF, International Classification. The trouble is this, that the issue is this, that if you use SNOMED CT, you do not need to use any of the rest. LOINC, yes, to some extent. LOINC does offer certain advantages, which also SNOMED CT does, but you have to do a little bit more designing for that. But the rest of it, you can take care, and in fact, maps are already available for a number of SNOMED CT terms to ICD-10. The others are, for messaging, we have made HL7 v3.0 RIM. I must inform you that this is now being superseded by FHIR, F-H-I-R, a new standard which has come up from HL7. But frankly speaking, if you go to any commercial entity, they are still using HL7 v2.x world, and that is fine too. It is much easier to work with. People find it much easier to work with. Reference information model was very, very challenging. For imaging, it is DICOM, and although this particular version PS 3.0 2004 has been recommended, if there are subsequent versions coming up, it's perfectly okay to use them. For clinical data format, CDA 2.0 or ASTM CCR. In fact, CCD also, that is missed over here, but the clinical care document, which is actually basically an amalgamation of CDA and CCR, is also perfectly okay to use. There we have what EHR Standards Committee has done is provide a minimum data set, because there is a lot of issue which we were facing, that EHR, somebody was saying, well, if I have to design a EHR, I mean, I have no idea, how do I do that? And what fields should I have there? So in order to ensure that a basic minimum data is continuously available, this is only the broad ones which have been done. The individual items with what are the field is supposed to be for, and what is the data type, what is the data length, what are the possible data values that you can use, have all been specified. It is quite extensive actually. So you are having the patient demographics, the observer details, that is the clinician details, the reasons for visit, allergies, immunization, clinical observations, investigation orders, investigation results, treatment plan, outcome, date, time stamp, all of these have been specified. And I can also tell you that it is not that everything has to be entered. The security mechanisms which have been proposed are authentication, role-based access control, data verification, transport level security, encryption mechanisms, data storage, audit log, anonymization. We have also specified, like supposing you have a record, a set of records, and you wish to use them for research purposes. So how can you use that? What is the mechanism by which you can go ahead and have those data available? Then there were also ethical and legal considerations like data retention policy, patient policy or confidentiality, like what are you going to do, patient consent, quality of service, data ownership. So it's been very clearly specified, patient is the owner, provider is the custodian. Non-repudiation, you cannot say no, I didn't create that record, and dispute resolution, that is also been provided for. It's also very interesting that these EHR standards are not etched in stone. They are supposed to undergo periodic revision. In fact, they are currently undergoing revision, and meetings are scheduled to be held so that the next 12 monthly revision exercise is completed and you can get the latest ones. And this is a living document. Without giving out too much details, I can only tell you there is not going to be much of a sea change in anything. If you follow the previous one, the next one is even simpler to follow. And as a special observation, I've already mentioned this. The SNOMED City is available and you can use it, and that's all. Thank you very much.